So let's talk about some of the special concerns of adverse events with each of the drugs. And we've all been using imatinib for a long time and are aware of the GI toxicities, edema, rashes, for example. Dasatinib, about a third of patients will develop pleural, usually less commonly pericardial effusions. You have to stop the drug. How do you manage that?
Yeah, I do stop the drug. When I have that, I think, although sometimes there's a tendency of just reducing the doses and giving them management, I think that the best approach is to stop the drug temporarily, manage the pleural effusion. There's been some suggestion that corticosteroids may be helpful in some patients. Of course, if it has a lot of symptoms and other manifestations, you can drain do thoracentesis. Diuretics, it's controversial how much they work, but we frequently use them anyway. If you do all these things and then lower the doses when you resume the therapy, many patients can continue therapy and do well. Yeah. Some patients will have recurrent, and if you have recurrent, especially if it requires thoracentesis more than once or twice, I think you need to consider changing therapy. But many patients who have had a pleural effusion are able to resume therapy safely. Even if they have a recurrence of a very tiny pleural effusion, as long as it's not causing symptoms or other manifestations, that is fine.
Yeah, I agree. And I found that you can continue to dose reduce. I've had patients down to 20 milligrams a day of dasatinib remaining in complete molecular remission, if you allow me to use that.
Yeah, absolutely. And I think you make a good point, because we've emphasized too much the dose and all of that. And that's important. But we've also looked at patients that reduce the dose. And they can maintain their responses. So particularly a patient who's responding well already, those patients can maintain a response with 20 milligrams.
Exactly. We don't have drug levels, but we have a beautiful way of monitoring response.
Perfectly. Yeah. Exactly.
How about QT prolongation with nilotinib? How much should we be concerned about that? How do you manage it?
Well, QTc prolongation is one of those adverse events that we never paid attention to for many years. If we and there's drugs that we use that cause QTc prolongation that we never thought about, that Zofran and quinolones and things like that. Certainly with nilotinib, it is an issue that needs attention. You don't want to put a patient unnecessarily at risk. And there is some QTc prolongation, by the way, with dasatinib as well. What I do is, you want to check their electrolytes, because a patient that has hypokalemia, hypomagnesemia, they're already at risk of QTc prolongation. I tend to do a baseline EKG on that patient. And then I may want to do an EKG after about a week on therapy to see if there's been a significant change. It's rare that you find a patient with a significant change. If I don't find it, then I don't think you need to continue checking EKGs constantly. Maybe if you add a drug that has a significant risk of QTc prolongation or a significant drug-drug interaction and you have no choice, okay, maybe it's worth doing another one again. For the majority of patients, I think if you check once and you see that they're okay, then you're safe.
I practice the same way. How about the GI toxicity that we see with bosutinib? Any hints about how to manage that?
Yeah, the diarrhea is the biggest issue with bosutinib. Fortunately, it's more of a concern in terms of the frequency than in terms of the severity. It happens in about 85% of the patients, but the overwhelming majority are grade 1 or grade 2. It is also very common that over the first few weeks or maybe a couple of months, it improves significantly on its own. Sometimes it even goes away, but certainly it improves in the great majority of patients. I advise the patients that they can take any anti-diarrhea medication, Imodium, Lamotil. Most patients don't take them. They don't feel like they need to take it. I still offer them to have it with them, particularly in circumstances where they know they're going to be out, or in a situation where you don't want to be having a problem trying to find a bathroom or something. So, but I think the majority of patients can be managed with that. Now, it is also a dose-related issue. So, on a patient who's responding well, If it continues being a problem, you can also lower the doses of bosutinib, and that helps in that regard. So the majority of patients, even though you'll find it in most patients, well, first, it's also important to let the patient know that that's likely to happen, because they're prepared and they're more willing to work with you and communicate with you. But also reassure them that it is very likely that it'll get better over time.
You start with a lower dose of the bosutinib. I mean, the Bella trial, that's what was done.
That's correct, and even on the second line therapy, although the standard dose in second line is 500 as opposed to the Bella front line, which is 400. I think particularly in patients that I have a little bit more concerned, either because of their age or because they have other risk factors for GI or whatever, yeah, I tend to start with 400 and sometimes even 300, and then if needed, build my dose up over a couple of weeks.